Hello, everybody, and welcome back to another episode of Hybrid Healing Hour. Today, we're going to talk about Polycystic Ovarian Syndrome, also known as PCOS. This is a very common problem that we see in our society a lot with women, and we'll get into more detail. But first, I want to welcome our guest, Erin Blood. So, Erin, tell us a little bit about yourself.
Hi, thank you. Well, first, I'd like to say thank you for having me. I'm really excited because in my hormonal journey over the years, I've seen a lot of women with PCOS that I haven't been able to help because it's very underdiagnosed and it's very hard to get to the right physician or practitioner to help them with it. And I'm a pharmacist. I'm not a physician, but I do specialize in bioidentical hormones, and that is my passion. So I started out doing compounding about 13 years ago. And in compounding, one of the things that pharmaceutical compounding is one of the things that we do a lot of is bioidentical hormones. And we do a lot of other things, but the hormones just happen to be what I was very passionate about. And every time I did any education or seminars, they were always hormone related. It's just the path that I was drawn to. So when I would see the patients and hear their stories, that is actually what got me into working more with hormones, because it was devastating and they were just crying, coming from their doctor's office, maybe 5 different physicians, that they were just being told, no, there's no labs for that. Everything is fine. There's nothing wrong with you. But, nobody ever looked at their hormones, and
Exactly.
Their hormones were depleting and they're suffering from it.
Exactly.
Yeah. So that's why I got into bioidenticals, and it's been amazing. And yeah, I love it.
And there's so much you can use bioidentical hormones to treat, like so many symptoms and disease processes. It's more than just menopause.
Yes. So, when, first women will start losing their progesterone and, the sleep goes first, then the energy, the anxiety, the depression, the moodiness, irritability, and they usually get put on an anti-anxiety, a sleeping pill, and an antidepressant, which is really, doing them no good. It's actually more harmful if you look at the side effect profile of those things. It's just potentiating the symptoms they already have.
We couldn't agree more.
Yeah, unfortunately, women's health is severely neglected in this country, and I'm really glad that there are people like you out there helping women when they have no place else to go.
Yes, thank you. And getting back to the PCOS, of course, that's a really tough one, because not only as women are undertreated for menopause, PCOS is even more undertreated.
I think a lot of times with PCOS, it's treated with Band-Aids, and that's we're going to dive right into today. So PCOS, Polycystic Ovarian Syndrome, it's got the name ovarian in it. So we assume it's an ovarian condition. We assume this is a gynecological condition. So many women go straight to their gynecologist. But Doc, why don't you go ahead and tell us what it really is?
Yeah, so that couldn't be further from the truth. It's an endocrine disorder that's more related to diabetes and metabolic syndrome than it is to any ovarian condition. And my analogy that I use is calling PCOS, polycystic ovarian syndrome, is like calling diabetes burning foot syndrome, right? And sending someone to a podiatrist for treatment. That's just a symptom. That's not really the underlying disease.
If they had diabetes, right, and had burning feet. Yeah.
Exactly. And so how does it affect the ovaries? It affects the ovaries by producing cysts in the ovaries, and so what's the finding that you see on ultrasound?
A string of pearls. So there's one thing that's different is just because it's called polycystic ovarian syndrome. So there's a difference between having cysts on the ovaries versus actually polycystic ovarian syndrome. So you have multiple small little cysts seen on the ovaries that are less than 1 millimeter size, and it's actually in a string of pearls. That's what it looks like on the ovary. I mean, a female might develop other cysts, but it doesn't mean they have PCOS.
Right. And correct me if I'm wrong, but is it also the case that you don't actually have to have cysts on your ovaries and you can still have PCOS? Because I've had a lot of patients tell me that too. And they say, oh, no, I don't have any cysts on my ovaries, so I don't have PCOS, but not necessarily.
You're exactly right. In fact, let's talk about the Rotterdam criteria. There's something that was formulated to help people learn how to diagnose.
Yeah. So what happened is there was no consensus on PCOS for many years. And think about it, it's probably been around for hundreds of years. And it wasn't until 2003 that the American Society for Reproductive Medicine and the European Society for Human Reproduction and Embryology got together in Rotterdam and came up with the Rotterdam criteria for PCOS. And that combined a combination of ultrasound and physical markers. And based on their findings, you have to have 2 of the 3 criteria. So the 3 criteria are oligo-ovulation, which means decreased ovulation, or anovulation, which means you don't ovulate. So that's one criteria. Then you have to have hyperandrogenism, which means that you produce an excess of androgen hormones, which leads to things like facial hair, which is called hirsutism, or high levels of testosterone. And the third thing is polycystic ovaries visible on ultrasound. Now, you're absolutely right. You don't have to have ovaries on your cysts, but so many people believe that's the diagnostic criteria for PCOS. And it's not an uncommon disease. It's reported that anywhere between 15 and 20% of females have some form of PCOS, which makes it the most common hormonal disorder among women of reproductive age.
Mm-hmm. And even though we have this criteria, as you said, Erin, how many people out there are going out of their way to try to diagnose PCOS for their patients who come in with multiple different symptoms?
None.
Right. It's hard.
Unfortunately, I've actually, before I got to you, I reached out to probably about 4 other practitioners that I work with and asked them, I have a PCOS patient that I'm looking for somebody to help me with, and you were the first one. So thank you. That's great. And she is ecstatic, I have to tell you, because she's been to countless doctors over a period of 9 years. And I mean, this is why I do what I do, because she's literally in tears of joy, because she's finally just the thought that somebody's actually hearing me now and understanding me and willing to help me.
Yeah. And I just don't understand why people don't take it seriously. I mean, it's a quality of life issue. And I hear this story so many times that people are just suffering and not getting any answers. And even if they are diagnosed with PCOS and diagnosed correctly, that doesn't mean they're actually going to get treated. Mm-hmm. That just means they're going to walk around with a diagnosis.
Oh, absolutely. They hardly ever get treated. And unfortunately, if they do get treated, the only thing they're treated with is birth control pills, which is, I hate to say it, but toxic and horrible for you. And it's only treating the irregularities of the menstrual cycle. And it's not treating all of the things that are causing their decreased quality of life and their depression and their anxiety. I mean, some women, you can just look at them and know, okay, that woman has potentially PCOS.
And just because we're regulating their cycle doesn't mean we're helping them, right? A lot of times they still have many, many other symptoms. So some of the symptoms that we tend to see common with PCOS, and you can have one of these, you may have all of these. And that would be hirsutism, which is also, often seen as kind of male pattern baldness or losing, or I'm sorry, hair growth, opposite. Hair growth in the male pattern.
But both.
For women.
Both, right?
Exactly. So where do we see male hair growth is on the face, right? A lot of times on the face or right on the belly in that linea line there. So a lot of women complain of having more chin hairs than somebody who does not have PCOS. And you might also see hair loss in the male pattern balding areas. With that.
Yes. And the weight gain in the belly and the abdomen and the acne, those are usually the telltale signs that are,
but not everyone is overweight. You can have skinny people, that's why it makes it so difficult to diagnose. And typically the weight gain is due to high levels of insulin. And menstrual period irregularity. That's a big one, right? That's what we see quite commonly as one of the first symptoms. Women come in and say, I only have a period every 2 or 3 months, or I don't have a period at all.
Or it's been years since she's had a period.
Exactly.
And then you have the infertility issue, and it's quite traumatizing. Mm-hmm. It's a quite traumatizing disease
and they may also have like extremely painful periods.
When they do.
Mm-hmm. And then there's things that people don't think about, things like mental health issues. Anxiety and depression are very common in women with PCOS. Sleep apnea is something that's vastly underdiagnosed in this country, not just for PCOS, but for everything. But I think that that typically goes along with the weight gain.
And I think some other things that go along with the weight gain is like hypertension or high blood pressure and high cholesterol, known as hyperlipidemia. But as you mentioned, Erin, I think we also see some gut issues with that too. Sometimes some irritable bowel syndrome can be seen, which can be associated with sometimes what meds you might be put on can affect that, right?
Yes. And unfortunately, sometimes it's the wrong meds that are actually potentiating instead of helping them. And, a lot of, it's also so misdiagnosed because we look at low progesterone, but we don't really acknowledge low progesterone in young women. We're not even acknowledging it in perimenopausal and menopausal women. So
absolutely,
they're never being addressed. And that's half the battle right there with their sleep and, energy levels and weight gain. Mm-hmm. And then again, they're just put on birth control pills instead of progesterone, which is what they really need.
Yeah.
And so we've talked about, testosterone and whatnot, but what are androgens? Because this is technically associated with high androgens.
So androgens are your testosterone and DHEA. Those are the main ones. And this is not necessarily a high testosterone issue, although a lot of people think of it as a high testosterone issue. Actually, it's a high free testosterone issue. And the free testosterone is typically high because their sex hormone binding globulin is low. And then with DHEAS, that's a hormone that's secreted by the adrenal glands, and it's actually the most abundant circulating steroid hormone in humans. And it's converted into either estrogen or testosterone in the body. And there's plenty of cases where we need to give people DHEA, right?
Yes.
I'm sure you do that a lot in your practice.
I do. And in the women, the DHEA, when we're talking about perimenopausal and menopausal women, the DHEA seems to drive up their low testosterone levels very nicely. Whereas in the PCOS, they may or may not need that depending on, if their free testosterone is low, then sure. But yeah, that they seem to have, you see it both ways. Sometimes they have high testosterone, sometimes they have low testosterone. Yep. So that's another tricky part of PCOS as well.
It is. And I think you said the word tricky, right? So PCOS is very tricky on how to manage it. And I think that's what fears a lot of providers out there, that they don't even want to bother to dabble in it, or one, they don't have time.
Oh,
right?
I think that's huge. I think that they definitely don't have time because again, I know I compare a lot of things to perimenopausal and menopausal hormones, and I know how difficult that is to treat. But then when you take something like PCOS, and not only are we looking at the sex hormones, but we're looking at the adrenals and the thyroid gland and the metabolic syndrome with the diabetes, it gets a little bit overwhelming even for the practitioner.
Exactly. And as we were discussing before, just because they have high testosterone, a lot of these women have low libido or low sex drive. This can affect their energy. This can affect their relationships, right, with their significant other. Mm-hmm. And so one thing that we've learned and what we do in our practice is we still can treat people with hormones, including testosterone, but we just start low and go slow, and we can really optimize how they feel.
Yeah.
And it doesn't mean it's going to worsen their symptoms. So how do people get PCOS? I know this is a big question. But I think it's more multi-level, right? It's more complicated than people think.
Yeah, it's, we do a lot of work with autoimmune disorders, right? And all these things are related. There's so many things that we're being bombarded with in our environment. So let's start with genetics. Everything boils down to genetics, right? And patients who have a mother or sister with PCOS seem to have a much higher chance of having PCOS themselves. And then there's epigenetics. That's one of your favorite topics, right?
Epigenetics is where you can actually change your genetics, based off your environmental exposure.
Yeah, or modify the effect of your genetics.
Right.
Chronic inflammation. Inflammation is everything. Everything that happens bad in our body is inflammation. Heart disease, but absolutely PCOS too. And oxidative stress.
That's the toxic effects of the production of peroxides and the free radicals that damage the components of every cell in our body.
And then I'm sure, Erin, you're on the same page as us with lifestyle, right? Diet.
Oh, yes. Diet, exercise, eating healthy.
That should be the number one treatment for everything. No matter what you come in with, number one is going to be diet and exercise. So what's the diet that you need to
particularly, once it's associated with metabolic syndrome, also associated with prediabetes, insulin resistance. So therefore, we want a low carbohydrate diet, right? And ideally low dairy, because dairy is also associated with high inflammation and hormones. And we also would recommend low gluten or gluten-free, actually, because we've always had a comparison here of, gluten is so inflammatory that it's either an all or none concept. You're never partially pregnant. You're pregnant or you're not pregnant, right? So we recommend a completely gluten-free diet, which therefore, usually if people just cut out the crap gluten-free foods, they're essentially not eating very many carbohydrates in.
Right.
And then, of course, stress. Who isn't stressed out these days?
Yeah.
So that's stress causes inflammation. Stress causes you to eat bad things. It causes you to not sleep well. It causes decreased metabolism and all around.
Yeah. And then even if you do balance your hormones, when your stress and cortisol levels are high, well, if they're not functioning at their...
Exactly. People need to understand it's not just here, take this and you'll be fine.
Right.
It's a multi-system approach.
Yeah, you got to manage the stress along with the lifestyle and diet and exercise. It's a huge component that, again, is overlooked.
And there's also a ton of environmental exposures, right? There's toxins in our everyday life that we're exposed to that completely disrupt our endocrine system.
Right. And then we have no control over that, unfortunately, or very little control on that part.
Exactly. Like BPA, right? So now you see all these plastic bottles out there that say BPA free, right? But what you don't know is receipts at your store, at your grocery store, at your gas station, receipts have BPA on them. So every time you touch that, you're getting exposed. And a lot of people don't do that. I recently stopped collecting receipts. If I can, if I have every opportunity, I'm like, oh, that's why I like that they're texting it or emailing it now.
And BPAs mimic estrogen. That's where the problem is.
So then you can have elevated symptoms with that. Also, there's atrazine, which is a chemical sprayed on crops, and that mimics estrogen. So we recommend buying organic or wash and cleanse your fruits and vegetables really well.
And phthalates, which is spelled with a P, but it's phthalates, which is in plastic wrap fragrances. And what's the smell that everybody loves? It's the new car smell. And the new car smell is actually a product of phthalates that are in the car.
It's from the plastics in the car. And I know when I found this out, I was really sad because I do love that smell. And then arsenic. So a lot of people don't realize that we are exposed to arsenic. So it can be found in herbicides or algicides. But I will say in the United States, it was phased out of domestic pesticides. However, commercial use of imported arsenic is still high. It's actually it is and has been used medicinally. Most commonly, and I found this shocking, in chemotherapy drugs, but it makes sense how you want to give a bit of something toxic to kill the cancer. That is what chemotherapy is, unfortunately. But and then it's at very low doses. So ideally, once your cancer is gone, then that can be excreted through the body and you can move on. But otherwise, this affects overall carbohydrate metabolism.
Yeah, and then there's organophosphates, which are pesticides, and they affect acetylcholinesterase. So that's one of the reasons why we tell our patients the dirty dozen, right? The fruits and vegetables that you should stay away from versus the clean ones that you should eat safely.
We have a little card in our office.
Oh.
Yeah. Mercury, which is exposed in fish mostly, and then it can also be in some water and byproducts.
Groundwater, yeah. And PFCs, which are typically found in nonstick cookware or stain-resistant fabrics. All of these things we're exposed to every day, no matter what. However clean you think you are or however clean you try to be, you can't avoid these things. They're there.
And these are the drivers. These are the things that can change your well, not change, but modify your genetics, or I'm going to say light them up. You know, if you can avoid these, they might never get triggered, you know.
And then something we always talk about, and I'm sure you probably do, is the gut, right? The microbiome.
Yeah, the second brain.
Exactly.
Microbiome dysbiosis. That is huge. That controls everything. And one of our pet peeves is antibiotics, right? We try our best not to write for antibiotics. We have patients all the time who come in and say, I need an antibiotic for this, and we talk them out of it. Yep. We just heard recently that the number one users of antibiotics are dentists and urgent care centers. They're responsible for most of the antibiotics written in this country. So I urge everyone who's listening that unless you're really sick, try not to take that antibiotic, because it's not just killing the bacteria, it's killing your good bacteria.
Mm-hmm. Well, and talking about some symptoms of the PCOS, you have acne, and it's from oily skin. And here's the thing, people might go to a dermatologist to treat their acne, but if we're just treating the acne, you're not getting down to the cause of it.
The underlying condition.
Exactly. And that's from the gut. And how many times, Erin, have you seen people get on antibiotics for acne? I mean, doxycycline.
And they're on them long term, and it's really, I mean, it's like a nuclear bomb going off in your body. It's not a good thing.
Well, and that's exactly, you're exactly right. It just completely ruins the gut lining. It creates resistance, and
and what is the cause of the acne? That is what really should be the question, not just, let's kill this bacteria that's causing it. Well, what's causing that?
And why are they put on it long term? Because the moment they stop, the acne comes back. Exactly. Yeah. So we have to figure that out. And that's exactly, even if you do topical, there's topical antibiotics and everything, but all of this should be just short term. Mm-hmm. We do not want to continue. We do not want to prescribe those. And fiber is very pertinent for the good gut, right? It's feeding the bacteria in your gut.
Prebiotic.
Yes, it is considered a prebiotic, and so it's very important. A majority of people in our society do not get enough fiber in their diet. So, and it's okay to supplement with fiber. Mm-hmm. So, are there any natural remedies that can help PCOS?
So, fixing some of the underlying deficiencies helps. So it's important to, maybe have your vitamin D level checked. Make sure that's optimal. Maybe you have your B12 level checked. But then there's things like inositol. Inositol can correct underlying metabolic issues and can restore regular ovulation. N-acetylcysteine, also known as NAC, can help reverse insulin resistance by improving the insulin response to glucose. And we actually put a lot of our pre-diabetics on that supplement. Berberine. You like berberine, right?
Yeah. Isn't that the poor man's metformin, even though metformin is pretty cheap now.
Berberine is great.
Yeah, that can reduce testosterone, fasting glucose, and fasting insulin levels. Perfect. I know it can help you get into fasting as well. So I'm really big on the whole fasting. We do the time-restricted eating protocols in our office, and we typically only eat within an 8-hour range ourselves or even less. And so that alone is beneficial, but I know if I've done a lot of research that taking berberine can also help expedite that and get you into fasting sooner.
So the people who get diagnosed with PCOS typically are the women who have not reached menopause, right? The women who are younger, but nobody thinks about what happens to patients with PCOS after menopause. It still exists. It's not gone away. The problems are still there. Right, so they have some separate, different issues. They can continue to experience the androgen-related symptoms. They can have severe worsening vaginal dryness, worse than what non-PCOS menopausal patients have. So I think that very few doctors who would even bother looking for PCOS or diagnosing PCOS would look for PCOS in a postmenopausal patient.
Right. So I have a question. If a woman has more severe vaginal dryness in menopause, is that something that would, make you think, I wonder if she has PCOS?
Could, if it's pretty severe. I mean, it's something that you have to think about, especially if they're insulin resistant or have any of the other things that we talked about on that list. Any of the other, the hirsutism or male pattern baldness. And we have so many women come to us in our practice who have hair loss and cannot find the cause of hair loss.
And one of the things that, since we do hormone replacement therapy in our office, we use a lot of DIM. And DIM is a great hormone balancer. It can also help with androgenic side effects such as acne. But one of our products also has shilajit in it, which comes actually from the Himalayan rocks in the mountains. And this helps also regulate the menstrual cycle, which not pertinent to postmenopausal, obviously, but balances hormones, and it can reduce their insulin resistance. And
that's a supplement probably very few people have heard about, but I would encourage you to read up on it.
And that can also help, it kills two birds with one stone with that postmenopausal woman.
So I'm sure that, Erin, you have the same frustrations with the healthcare system that we do. And the biggest frustration is, how do most doctors treat PCOS?
With birth control pills.
Exactly.
Which, again, it makes me cringe. But
you're just treating the menstrual cycle. That's all you're treating with that. And there's so many other downsides.
It's just another Band-Aid that's really just not working, and the patient's just suffering, and none of the underlying conditions in that case are being addressed. Yeah. And there are a lot of them.
And before we go into some other pharmaceutical treatments, let's talk about the testing, because I think a lot of providers out there are not running the testing that's necessary to be able to diagnose PCOS.
Yeah, the testing, again, even when I said earlier, a lot of times the only thing that, they're doing is CBC and, a metabolic panel, but nobody's looking at their hormones, even in a postmenopausal woman. They're looking at estradiol and FSH, and that's about it. And, that's another thing. Women come to me and say, well, I was told there's no such thing as a hormone panel. What? No such thing as a hormone panel. And if they don't get to a functional medicine doctor, a lot of times they're not being treated properly. And it's really just a shame, because there is so much treatments out there. But as far as the lab testing, there's so many other things that we can look at: the testosterone levels, the DHEA, the insulin, the hemoglobin A1C, to look at the metabolic panel for the glucose in the metabolic syndrome, as well as the sex hormones, and again, the adrenals and the thyroid, which is really important too, because so many of these things have overlapping symptoms that they're oftentimes misdiagnosed. Mm-hmm. And so all of those things have to be looked at. It's very comprehensive, but it's necessary to figure out what's really going on.
Right. And out of our PCOS patients who come to us, as new patients, how many of them have any of that tested before? Probably none. Yeah. Right. Yeah. And it's maybe an A1C, but it's shocking.
Yeah. And what would be so important is for it to be part of the norm, and to have a baseline to be able to see the difference as we're aging.
Absolutely.
Which never happens.
Yeah. And I think a lot of times doctors don't want to check these things, because then they're going to have to spend the time to go over it.
Yes, right? I agree.
Homocysteine is another big one. We love homocysteine. It's a marker for the deficiency of vitamin B12, B6, and folic acid, but it can also indirectly assess levels of inflammation in the body. And fasting insulin levels. That's a test we like, although that's a little more controversial, because that can be all over the place in some people. But you mentioned something earlier. There's a lot of different conditions that can mimic PCOS, right? And so what are some of the things that can look like PCOS but aren't PCOS?
The Cushing syndrome, thyroid dysfunction, congenital adrenal hyperplasia, pituitary tumor, hypoprolactinemia.
Yep, and adrenal adenomas. So adrenal adenomas are something that are interesting. They're vastly underdiagnosed in this country, and that's a test called a dexamethasone suppression test that can identify that. And these are little tumors in the adrenal glands that produced high levels of cortisol that are completely different from Cushing syndrome, which is what most people think of when they think of high cortisol levels.
Yeah, and cortisol is very important to check in general, I think, when you're associating anything with insulin resistance of fasting cortisol, or sometimes we do a 24-hour cortisol where you do a swab or spit or urine throughout the day.
Not only with that, but also I like to always include that when I'm working with patients on their hormones, because I like to always look at the thyroid, the adrenals, and the hormone panel, because they're so one is just affecting the other. And unfortunately, again, the adrenals are, unless you have Cushing's or diagnosed with one of those, they're just completely omitted and dismissed.
You can't treat one without the other.
Right. And it affects every single one of your hormones, just having those cortisol levels out of balance and having a high cortisol level or hypoadrenalism, whichever you may have, whatever state you're at. But it interferes with every single one of your hormones. So we can balance them, and you're still not going to get the most out of it without addressing the adrenals. And another thing that I've seen is the thyroid. When the thyroid can't, when there's so much fluctuations and you treat them with Synthroid or Armour Thyroid or whatever, and then it's just, it's probably Hashimoto's, so it's a lot harder to treat, but nobody looks at the adrenals with them. And a lot of times you just need to step back, look at the adrenals to help get the thyroid under control.
It's hard enough to get people to look at more than just the TSH when you're talking about thyroid conditions.
Exactly.
I mean, you got to check the antibodies,
Yes.
And the free T3, the free T4.
And the reverse T3, which it's so many, that's another thing patients will tell me, well, I had my thyroid panel and everything looks good. And I'll say, oh, can I just see a copy of it? And the only thing that's on there is TSH and T4. Well, how do you know?
Yeah.
And same with hormones. If, my gynecologist checked my hormones and I see estradiol.
Fine. Yeah, estradiol.
and progesterone. That's it. I'm like, well, okay.
Lucky if you see progesterone. It's usually just estradiol and FSH or an LH, and that's it.
Yeah.
So yeah, there's so much, if you want to get down to it and find out what's really going on, you have to do these labs and.
Exactly. And so therefore that leads us to the treatment options, right? So if we can figure out what the causes are, we can treat that. And I mean, a lot of times we always start with a lifestyle first in our practice. So we always start with, we recommend fasting. As we said, there's so many benefits to fasting. It alone reduces your inflammation. It helps the gut. A 24-hour fast can really reboot your gut. It's amazing. And exercise, right? Specifically, actually for PCOS, we specifically recommend high intensity interval training, also known as HIIT. We recommend just a short burst of this though. Like, I don't recommend you to go to cycle ward and cycle for an hour at high intensity,
right? Because
then it's like,
that's another stress on your body, a physical stress. And
people don't realize this. So
right.
I'm talking a 10 to 15 minute high intensity interval training, would be fabulous just to get, your body moving, right?
Mm-hmm.
But not stressed out. And so this has been shown to improve metabolic health and improve PCOS symptoms, actually. Now, let's talk about the medications. Erin, what are the ones that you recommend most when we come to treatment of PCOS?
Well, usually their progesterone levels are low, so we want to use bioidentical progesterone, not birth control pills. We want to look at the testosterone. That's usually high, like we said earlier. So we want to do something to lower that if that's the case. And if not, address it accordingly. And then we also want to treat the metabolic syndrome with metformin or semaglutide. And then the other thing to regulate the testosterone is spironolactone. So those things are the, kind of the first line of therapy, which...
Yeah, they're the go-tos.
Yes.
Right?
And if we could reiterate, and we've talked about this before on other podcasts, and we will talk about it again, synthetic progestins are bad.
Oh, horrible.
And that's what people get when they get birth control pills.
Yes.
Right? And that's the ones that cause everything bad that happened in the Women's Health Initiative and all the other bad clinical trials that were done. Yeah. We're talking about micronized progesterone as being the one that we recommend for people.
Right. And not only progesterone, but all of the hormones. The birth control pills also contain synthetic estrogens too. So when we're talking about any of these things, we're talking about bioidentical hormones, including the estradiol, progesterone, testosterone, DHEA.
Why do we call them bioidentical?
Yes. A lot of people don't understand that, so that's really important. So bioidentical, meaning that it's exactly identical to what our body produces. And one way I like to describe this to patients so that they can understand is that birth control pills or synthetic progestin, medroxyprogesterone acetate. Those are synthetic progestins. I don't even like to call it a progesterone. So when you do lab work, those aren't going to show up in your labs. It'll be nothing because it's not recognized. If you're using bioidentical progesterone, which is what is being recognized and looked for, it will show up in your labs and you'll see the difference. And one more point that usually kind of drives this home is that for women that have miscarriages, when their progesterone levels are low, we can actually give them bioidentical progesterone vaginal suppositories to help prevent the miscarriages. We can never do that with a synthetic progestin because it's teratogenic. Mm-hmm. So, I mean, that just kind of really gives a good picture of the enormous difference between bioidentical and synthetic. And I think also it's very difficult when people are trying to look it up on their own, because when you look on Dr. Google, they're not defining bioidentical and synthetic. They're just talking about how horrible hormones are. Mm-hmm. And yeah, synthetic hormones are horrible, but bioidentical hormones are necessary for almost every system in your body. It is the aging process as they deplete.
It's not the same thing. And I want to go back for a second and talk really quickly about the diabetes medicines. Metformin is a good medicine for PCOS, but I will tell you that semaglutide, which is also Ozempic or Wegovy, or tirzepatide, which is Mounjaro, and there's just been released for weight loss now as well as Zepbound, right? Zepbound. Those are phenomenal drugs. I mean, we think of them as weight loss drugs or diabetes drugs, but they are great drugs for PCOS. And if you can find a doctor who will prescribe that for you, it's
a game changer.
Yeah, absolutely.
It does.
That's
so
great.
The bottom line with PCOS treatment is you have to be patient. It can take 1 to 3 years to restore fertility and to restore your menstrual cycle again and to fix symptoms. You have to do everything, not just medications, but it's lifestyle, everything else. But
there is light at the end of the tunnel.
Exactly. So, Erin, why don't you go ahead and tell everybody how they can find you or follow you?
Well, I'm at Premier Compounding Pharmacy in PGA, and I work there. I also do consultations at a wellness center. I also have a website. It's my name, erinblood.com, and that is like the blood that goes through your veins. ERINBLOOD.com is my website. And so I'm available and happy to help.
Thank you, Erin, for joining us today.
Yeah, it was great to have you.
Thank you so much. I'm really excited about the PCOS info getting out there because it's important.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.